Good evening, everyone. I'm going to present a case of primary angle closure glaucoma with retinitis pigmentosa. Prevalence of primary open angle glaucoma with retinitis pigmentosa ranges from 2 to 12%, whereas prevalence of primary angle closure glaucoma in RP patient over 40 years of age is seen between 1.03%. Intraocular pressure elevation due to acute angle closure may aggravate the visual impairment in retinitis pigmentosa patients with pre-existing optic nerve dysfunction. Angle closure related IOP elevation can be prevented by timely interventions in these susceptible eyes. A 34-year-old female presented with complaints of diminution of vision in both eyes, which was more in right compared to left, insidious in onset, gradually progressive, with symptoms aggravating in dim light or at night. It was associated with headache from last 2 days, severe in nature, not decreasing even after taking oral medication, and not associated with any diurnal variation. In ocular examination, the vision in right eye was 1/60, improving to 3/60 with pinhole. In left eye, it was 6/9. The pressure was at 10:30 a.m. In right eye, it was 38 millimeter of mercury, and in left eye, it was 36 millimeter of mercury. The cornea was clear in both eyes. Anterior chamber was shallow in both eyes. No AC pigments or cells were seen. The pupil was mid-dilated and sluggishly reactive. In lens, we found posterior subcapsular cataract was present in both the eyes. On fundus examination, waxy pale disc with temporal crescent, vertically dysmorphic disc, along with FR was dull, and severe arterial attenuation with bony spicules were seen all around in the periphery. Coming to the gonioscopy findings, in right eye it was seen till 8 am with blotchy pigmentation in 2 quadrants, whereas in 2 quadrants it was seen with till Schwalbe's line. In the left eye it was in superior and inferior quadrant, ATM with blotchy pigmentation was seen, and in temporal and nasal side, Schwalbe's line was seen. On OCT RNFL, in right eye, all the quadrants were outside normal limits, except the superonasal quadrant. In left eye, only the nasal, temporal, and central we could see outside was normal limit. So left eye AIOC was done in the left eye. Vision improved to 6/9, and the pressure was 11 millimeter of mercury. After 1 month, right eye AIOC was done to control the pressure in the right eye, but the pressure was still found to be increased. It was still 40 millimeter of mercury. Then phaco plus trap plus was planned for this patient. Right eye phaco emulsification with PCIL with trap with MMC was done for this patient. On post-op day 1, the vision improved to 3/60 in right eye. Along with the pressure was under control, it was 13 millimeter of mercury. Cornea was clear, PCIL was in situ, AC formed, and bleb was visible. Surgical PI was patent. The previous theories regarding glaucoma in RP suggest that the migration of pigment is the characteristic features of retinitis pigmentosa, and these pigments in the angle of the anterior chamber has been stressed as possible etiological factor in the glaucoma. Ultrastructure of the lens in RP is altered, causing lens fiber disorganization, which may contribute to the instability of the lens with anterior displacement and narrowing of angle. Recently, zonular instability is speculated to be the cause behind angle closure in RP patient. Zhong et al.'s exploration using whole exome sequencing discovered the 5 genes CRB1, COL2A1, RHO, RP1L1, and PAC6 responsible for the genetic association between early onset BACG and RP. The predisposing factors for ACG in RP were nanophthalmos, cataract, lens subluxation, increased lens thickness, anterior segment dysgenesis, and short axial length. The take-home message was the tubular visual field might be observed in the patient of RP or PACG at the late stage. Therefore, atypical glaucomatous optic disc, similar visual defects, and the incidence of rarity may lead to a higher misdiagnosis rate. Hence, comprehensive ophthalmic examination, including gonioscopy, full-field ERG, macular OCT, and genetic testing should be done in younger RP patients in clinical diagnosis. Early intervention and maintenance of target pressure can control these kind of visual problem. Thank you.
Thank you. Nicely presented, Pankhudi. Okay, so the demographics that you mentioned, is it inclusive of the atypical RP as well? Have you read about it?
No, ma'am, only typical RP's article was present.
Okay, so second question is, why did you wait for PI in the right eye? You waited 1 month. The pressure was 40 in both the eyes.
Ma'am, the pressure was not controlled and cornea was not clear, so that's
so why. Because the pressure is high, that's why.
Yeah.
So why was it? Why did you wait? Any specific reason for it?
After 1 month only, so that's why it was done after 1 month.
So why was it not done concurrently?
Ma'am, in left
You don't do it at the same sitting? Many people
same
don't do
sitting
it.
only unilateral it's done.
You do only unilateral at
Yes,
AIMS?
ma'am.
Okay. Right. Anything? Thank you.
Thank you, ma'am.